Well, while we're waiting, why don't I just say a few words about this is the first monthly seminar of the Hopkins Economics of Alzheimer's Disease and Services Center, which I have the privilege of co-directing with Dan Polsky. And we're really excited to hear today from Regina Shih, who I've been hearing all kinds of great things about, and in terms of the work that you're going to be leading that is focused on home and community-based services, which is of great interest to our center affiliates. While we wait for Catherine Ornstein to join momentarily, I just want to make a plug for our upcoming pilot RFA, which is out now and should be, I think the applications are due in February 1st. We had a optional letter of interest that we've heard from many of you, but it is not too late. So if you did not get your letter of interest in, please still feel free to consider putting in a full application, which is due in February, and you can reach out to me or to Chase Mulholland, who's here. We're happy to field any questions you may have. And it looks like our esteemed colleague, Catherine Ornstein, is now here to do the honors of and make introductions. So Catherine will be also moderating today's conversation. Take it away, Catherine.
Wonderful. Wonderful. Thanks, everyone, and thanks for being here. We have a fabulous speaker today, Regina Shih, and I am just thrilled that you agreed to come speak with us because your name is popping up everywhere. And probably what's most exciting, I'm not sure if everyone realizes, but you received your PhD here at Hopkins in the Bloomberg School of Public Health. Regina is a professor of epidemiology at Emory, the Rollins School of Public Health, and has a joint appointment there in the Department of Health Policy and Management and the RAND Corporation. Her research focuses on family and formal caregiving for persons living with dementia. And recent projects include program evaluation for the Bold Public Health Center of Excellence on dementia caregiving, Medicaid waiver and demonstration programs in New York, a policy blueprint for U.S. dementia long-term care. And her current projects include advancing healthy aging research with villages, improving measurement of dementia home and community-based services, mapping the social network of dementia family caregivers, and examining the role of historical redlining on dementia risk. Prior to joining Emory, she served as RAND's program director, overseeing the public health and social services research portfolio. We are thrilled to have you here with this HEDS community. We're all big admirers of your work, and we look forward to hearing from you today.
Oh, thank you so much, Catherine, and thank you, Jennifer, for inviting me along with your HEDS co-lead. I'm so honored to be here, so thank you. And it's nice to see some friendly faces and also be talking to you all virtually through a Hopkins venue, so things sometimes do come full circle. So I'm going to share my screen, and hopefully I did it correctly. You can give me a thumbs up or a thumbs down. Okay. So I don't feel like I have to introduce this idea to you all, but just because we're trying to level set, I wanted to just give a quick background about LTSS. So LTSS are medical and supportive services for people with activity of daily living needs. And more than half of Americans age 65 and older and will at some point need and require LTSS. And in 2020, an estimated $475 billion was spent on LTSS. That's about 14% of the $3.4 trillion spent on personal health care. Medicaid is the single largest payer of LTSS. But unfortunately, if you're not eligible for Medicaid because your income is too high, or if you can't afford private pay LTSS, you're kind of this middle class that's stuck. So I'm going to come back to that theme later. All right, so this is a very simplistic way of talking about LTSS, but I'll be primarily grouping things into 3 types of LTSS today. So I'm going to talk about this rebalancing from institutional care to home and community-based care. And that's an initiative that CMS undertook to try to rebalance, referring to the shifting of services and supports to home and community-based services, or HCBS. And that's generally because they cost less per beneficiary than institutionalized care, and because individuals prefer to remain in their homes and communities. Here's the bar graph from Kaiser Family Foundation showing spending trends over time on Medicaid HCBS versus LTSS. As you can see, it's grown substantially, but prior to 2010, there were major lags. And so rebalancing was a major effort that began prior to 2010 as a way to increase spending on HCBS relative to LTSS. Now, we talk about these two systems of care during this discussion about rebalancing, but the effects of rebalancing don't involve just those two systems. It has potential to impact individuals and family caregivers. Whether those impacts are positive or negative is vastly understudied. And so that's why I wanted to embark on this study of the Balancing Incentive Program, or I'll refer to it as BIP. So BIP was one of the nation's most comprehensive rebalancing initiatives. It was a major overhaul of the LTSS system authorized under the ACA, designed to help increase access to HCBS providers, bring people into the Medicaid system, help people transition out of institutions, and keep people in their lowest setting of care by avoiding institutionalization through things like the Medicaid HCBS waiver programs. Now, states were eligible to apply if they were spending less than 50% of their HCBS expenditures on of their total LTSS expenditures in fiscal year 09. And so CMS put out this application shortly after the end of fiscal year 09 and said, if you're spending less than 50% of HCBS relative to total LTSS, you are eligible to apply. And they, if states implemented, if they were applied, approved, and implemented, they were provided with an enhanced federal match. And there were three main components that these states had to implement. The first was a no wrong door, single entry point system. And that was so that anybody coming into the system could find the right way into receiving LTSS. Second, states were required to develop a core standardized assessment, and that was to ensure that individuals were asked about the same consistent set of information to determine functional and financial eligibility. And the third component of BIP was to ensure conflict-free case management, so removing potential biases from providers. So if you were an assessor, you could not then refer and prescribe or provide services. There were 38 states that were eligible for BIP based on that spending benchmark, based on that threshold, but only 21 states applied and were approved. 18 states ultimately participated because Indiana, Louisiana, and Nebraska withdrew early from BIP, all for very different reasons. Mississippi's benchmark was to reach 25% of their spending on HCBS relative to LTSS because they were spending less than 25%, whereas most other states were between 25 and 50% when they were eligible. So the initial rollout of BIP occurred between April of 2012 to October 2014, although some states continued to implement BIP afterwards. And so that initial BIP funding of $3 billion ended at the end of September 2015. So at the time I applied for NIH funding to evaluate BIP, there was no previous other evaluation. To date, since I've started this R01, which was many, many years ago, there has been one evaluation, and that was by RTI under contract with CMS. So I'll be talking about how our colleagues at RTI also did evaluation and how our study complements that of RTI's. So this 5-year R01 and a dementia supplement was funded by NIMHD. And so we looked at three things very broadly. We looked at states' application, the implementation and impacts of BIP. We also looked at the effects of rebalancing on workforce trends, institutionalization, mortality, and family caregivers. And then we also examined how HCBS access differed by race, ethnicity, rural, urban residents, and by dementia status. So I'm going to talk about these three topics in turn. So if you can imagine, we requested a lot of data from CMS. It took forever and a day. Our project ended December 31st, 2023. Our last years of data arrived on December 10th. So we are still analyzing data, which is super fun, but we wanted to get as many follow-up years as possible. So that's why we've been asking for new years of data every time they do get released by CMS. So I'm going to talk about, this is a mixed method study. So I'm going to talk first about the qualitative and then move on to the quantitative stuff, just because the qualitative stuff was being published while we were awaiting new years of data. So in the qualitative part of the study, we interviewed two sets of key informants. The first was 10 each across these 4 groups that we recruited from 38 BIP eligible states. And we were striving for diversity across the 4 geographic census regions and timing of BIP approval among BIP states. So some of the papers we published focused only on the states that implemented BIP, whereas others made use of all 40 interviews. The second set of interview participants we recruited for the purposes of the dementia supplement, because we were just focused on HCBS access for people with dementia. These were not just BIP states. So in that study, we wanted to get 1 representative from each of these 4 groups within the same state. So we picked 11 states with roughly equal representation across the 4 census regions, and we recruited 1 of each of those 4, roughly, in 4 groups from each of the same states. And we selected interviewees based on their expertise on the delivery of HCBS for populations with dementia. So I'm going to go through these research questions. We've published about 10 papers. I'm going to go through about 6 of those papers today. I'll go pretty quickly, so please stop me along the way if there's anything of particular interest. So to inform our quantitative work to evaluate BIP, we wanted to understand, how did states that chose to apply for BIP differ from those that did not? So I mentioned 38 states were eligible, only 21 states applied, and 18 participated. And the prior, oops, sorry, I'm going to go back. The prior research on the rollout, so that's why we wanted to know about the differences between states that applied and didn't apply. In the second research question, we had looked at prior research on the rollout of BIP, but they only came from a handful of governmental administrators and their perspectives on the rollout of BIP. And we really wanted to know, from the perspectives of all 4 groups, how did for these 3 other groups, how did the BIP application process go? How did the implementation of BIP go? In the third research question, we really wanted to know about health information technology. So you recall BIP had those 3 structural reforms that were required. States were also required to develop plans to use HIT systems to implement, coordinate, and maintain those components. So they had to create things like consumer-facing platforms, state-led websites, centralized databases. And that really was the first time that CMS used BIP as a policy vehicle for explicitly encouraging HIT in the LTS system. So we wanted to know, how did that go? And in terms of impacts, the 4th research question focuses on HCBS to LTSS spending benchmarks. And so, this quantitative metric of whether states met the 50% benchmark to receive that enhanced FMAP is a single quantitative measure of whether BIP had its intended impact, but it doesn't get at things like sustainability of impacts beyond BIP programming, or the infrastructure changes, collaboration between providers and consumer groups, or how to measure outcomes beyond this one fiscal rebalancing metric. And in the last question, we all know that there's well-documented disparities in access to HCBS for people living in rural areas and for racially, ethnically minoritized populations. And these disparities could be exacerbated for people with dementia. So things like stigma associated with dementia, cultural differences, and the LTSS system tends to focus on physical disabilities and less so on cognitive disabilities. So we wanted to identify unique barriers that might be faced by people with dementia. Okay, so I'm going to go through these findings one slide at a time. So in terms of application to BIP, our interviewees told us that reasons for applying to BIP included larger population size for their state, having supportive state leadership. So oftentimes they just said, we had one state champion who really wanted to apply for BIP, and that's all it took. And then other programs that might have existed that supported community-based care, like Money Follows the Person or PACE. Reasons for not applying included opposing policy priorities or a decision to pursue a different program that might be competing for similar resources. So we did end up looking at some of these kind of state level factors in our quantitative analyses. We also asked interviewees to describe the type and extent of engagement. So we heard the term, we categorized the types of engagement. And so things like informing or consulting non-governmental partners occurred, but largely collaboration and empowerment of providers and consumer advocates did not occur. And they talked about having a long history of working together. State governments, service agencies, and consumer advocates sometimes have longstanding conflicts or adversarial dynamics, and that could impede an application process or with the implementation of BIP. And so all four groups talked to us about what they thought could be changed in future efforts, like a big rebalancing program. So they said, if you put out an application for states to apply for these kinds of programs, you should build into the RFP a longer application period, more flexible timelines, and also requirements to engage with stakeholders that are non-governmental partners. And then score them on how well that engagement goes. And also maybe use neutral third parties like outside contractors to facilitate engagement between state and non-governmental stakeholders. I see Karen has a question.
I was wondering if you heard anything about whether this was a political decision in any way, or, does this application need to get approved by the governor? Does the administration matter, or was that pretty irrelevant?
We did hear that. And sometimes we thought, like, should we just code states as red or blue states as like a factor that we should adjust for? We did hear that. Definitely having a more progressive governor or an administration was more likely to be attracted to this enhanced FMAP. That wasn't the only reason, though. And so they did talk about political wins, but that was definitely not the only thing that came up. It was almost like we already have these other programs that are going to get us to the 50% benchmark. So why not go ahead and apply, because we're really close. Other states were also very close that were red states. They just didn't really want to accept the FMAP, the enhanced FMAP. So they were like, we're going to do it on our own through other means. And that's very broadly speaking. But yes, we did definitely think we just look at the voting maps and see if that helps explain differences.
Thanks. Fascinating.
Thanks for the question. Okay, so I'm going to move on to HIT. So most administrators described HIT as being of great value to implementing BIP, and they actually said that HIT was really needed to overhaul and modernize the whole LTS system. They also said that HIT enhanced a beneficiary's ability to self-direct their care by giving them and their family caregivers a single access point of information about all categories of services that were available to them. The providers also really liked it because they said the information about clients was all in one place and more accessible to everyone. So certain providers were not just getting information about certain types of clients. So it was more equal access for all types of providers in the HCBS system. They also cited some challenges. So they also said that there was a limited reach of HIT that was persistent for rural and disabled beneficiaries. They also talked about a really burdensome procurement process. So those states that implemented BIP said sometimes the delays may have been because it took a long time for us to get an HIT provider on board and to go through that procurement process. And of course, keeping everything evergreen and current, existing software being updated constantly, new applications, maintaining security standards was also a challenge. So I'll move to the culture change associated with BIP. So, and I'll focus on the consumer advocates. In our papers, we talk about the perspectives of all four groups. But I think it's important to say that the consumer advocates did note some positive impacts. They noted greater service coverage and a culture of patient-centered care that was not always there before BIP. And I don't know if this is a positive or a negative thing, but they also reported a higher bar to accessing institutionalized care. They also reported longer HCBS waitlists. And you may recall that in the second set of interviews, we were looking beyond BIP. We just wanted to look at HCBS more generally and for people with dementia. And so we noted that interviewees said that there was this often delay with a diagnosis and delayed entry. So Formal cognitive assessments and memory screens were not being conducted regularly. And they attributed this to providers' discomfort with discussing cognitive issues with consumers. And they said they really just don't have adequate training. And so one thing they pointed to was strengthening dementia competency and supports providers that could increase rates of early detection and diagnosis and reduce delayed entry hurdles for people with dementia. Transportation was mentioned as a pervasive barrier. Almost every single interview talked about limited or non-existent transportation services to connect people with HCBS services. And that had a lot of downstream effects. So there was, like, because of long distances to the pharmacy, there was inability to adhere to a medication regimen. Because of limited options to access respite care, there was more rapid health declines reported for people with dementia and caregivers. Because a local community was inaccessible because of transportation limitations, they also talked about extended social isolation and often also unnecessary institutionalization. And then lastly, interviewees pointed to a lack of non-English language services and information, and they cited that as a significant barrier to having an awareness of HCBS. Okay, so I'm going to move to the quantitative findings. And so you had heard me talk previously about this spending benchmark to incentivize states with BIP to get to that 50% benchmark of spending on HCBS relative to LTSS. Now, there's only been 2 other reports that looked at spending increases. So Kaiser Family Foundation, Watts et al., they examined data from 14 of the 18 states that participated in BIP. And they reported a 25 percentage point increase between fiscal year 2009 and fiscal year 2014. But you recall that the last year of implementation or approval was, the last year of approval was 2014. So states began rolling things out between 2012 and 2014. So they didn't really have a lot of follow-up after BIP was approved. And they also did not compare this to states that were eligible but did not implement BIP. In the second study, they did. So RTI used Medicaid state expenditure data. Karen et al. Reported an average 5.3 percentage point increase for BIP states, and they compared between fiscal year 2009 and fiscal year 15 for BIP states. They found that for non-BIP states, states that were eligible but didn't implement BIP, there was a 3.0 average percentage point increase. That translated to a raw subtraction of 2.3 percentage point difference. And so we're really hoping to do a little bit more of a causal, unbiased estimate to look at BIP versus non-BIP states. And so why do this at all? If there's an increased FMAP and the goal is to get to 50%, we know that HCBS, the ratio of HCBS to LTSS should increase. But having a spending benchmark does not necessarily mean that states met the benchmark. There was no penalty by CMS if a state did not meet the infrastructure changes or the spending benchmarks. So reaching that 50% was not a foregone conclusion. And as all you know, expenditures, as you all know, expenditures is not the same as utilization or access. So despite the major infrastructure changes with BIP, states could have imposed limits on HCBS waiver enrollment. They could have restricted the number of enrollees, potentially leading to long wait lists. So the impact of BIP can't be simply expressed as an increase in spending on HCBS that's attributable to receiving an enhanced FMAP rate. So in light of these more simplistic analyses, we sought to model unbiased causal estimates to examine the extent to which timing of spending increases compared to a counterfactual. What would have happened in BIP participant states if BIP had not been rolled out? So for those of you with eagle eyes, probably mostly economists, what's the problem with using diff and diff if you're looking at this graph? If you want to do this kind of more causal analysis of quasi-experimental design effects. Can't see the chat, but maybe somebody put anything in the chat, let me know.
We have economists on the call, but I don't see anything in the chat yet.
Well, so we have some economists on our team, and they did not see the problem at first either.
Wait, we do have a comment. there was a pre-2012 difference in trends.
Yes, thank you, Eric. So because there's this assumption of parallel trends prior to the implementation of a treatment, you can't use difference in difference methods, or it's going to be biased. And so what we did is we tried both. We tried a synthetic control method. And so we're working on this paper. These are preliminary findings. And what the synthetic control method does is it selectively weights candidate control areas, in this case, non-participating BIPs, non-participating states. And we used state-level observed characteristics so that the weighted control states have features that match those of the BIP participating states. This kind of method is suitable when you don't have parallel trends, and that assumption is not met, when the number of states is small, and it also accounts for unmeasured and measured confounders. In this analysis, we also included pre-BIP outcome years, pre-BIP outcome values for each year, and then we also aggregated outcomes from fiscal year 01 all the way to fiscal year 19. And so we considered pre-BIP and post-BIP, and we got data through fiscal year 19. So we believe we have the longest years of follow-up following BIP approval and implementation. And we also extended it to 2001 for our pre-BIP years to allow us as many pre-BIP years as possible. And so here's what we found, again, preliminary findings. We found that BIP states experienced an average 8.2 percentage point increase relative to non-BIP states. This is quite a bit larger than the 3.0 difference that, I'm sorry, the 2.3 percentage point difference that was reported previously. And so is that a good thing? Is that a bad thing? So Stephen Kay published a paper several years ago, and his colleagues talked about gradual rebalancing. And he described gradual rebalancing as a roughly 2 percentage point increase per year. And with that 2 percentage point annual increase, that can reduce spending by about 15% for Medicaid over 10 years. It's a substantial cost savings. Is an 8.2 percentage point increase during BIP implementation considered gradual enough to reduce spending? We did get some annual years as opposed to just 2001 to 2019. So more to come on whether anybody can answer this question. I don't know if it's going to be our group, but it is much larger than previously reported. These are also preliminary findings. This is a new paper we just submitted. Perhaps one of you on this call is a reviewer for our manuscript. If so, thank you for your service. In this paper, we wanted to look at whether living in a BIP state was associated with relief for family caregivers. The whole idea of HCBS is that maybe it costs less, but also maybe it relieves stress by family caregivers. But we don't know that for sure. So we used 2008 to 2016 waves of the health and retirement study. We have a time-varying binary indicator, whether BIP was implemented or not, and the respondent state of residence prior to their interview for that wave. And then we ran a series of probit models and then 2-stage models to look at hours of help. So we wanted to know, how likely are they receiving family caregiving help, from whom, and then how many hours of care? And what we found was that living in a BIP state was associated with reduced hours of care. It's a good thing. Provided by relatives and friends, but not for spouses. And so this suggests that spouses, who might be the most common family caregiver for older adults, might actually need to increase the time that they're caring for somebody, because maybe they're managing care in the home. They're also ensuring stable housing to facilitate home and community-based care. And there might be, they might be actually part of the whole eligibility assessment process and, coordination of services. And they're overseeing the care given through HCBS. And that's part of the hypotheses and the rationale that we've interpreted in the paper. So another preliminary finding that I wanted to share is about a more downstream outcome. So we wanted to know, is living in a BIP state associated with reduced rates of long-term institutionalization? Because that was the whole point of rebalancing. And so we used Medicare Current Beneficiary Survey and the MDS data set to look at survival analyses to time to long-term institutionalization. So a long-term nursing home stay, an episode of 90 or more days among Medicare enrollees in the MCBS. And we looked at data from 2008 to 2019. And what we found was that BIP was surprisingly not associated with hazards of long-term institutionalization, which is highly disappointing. However, interaction models showed that BIP exposure was associated with a lower hazard of long-term institutionalization among Hispanic enrollees. The opposite was true for non-Hispanic white enrollees. So maybe we could, yeah, I was hoping one of you might help interpret these findings. So Karen, I see your hand is raised.
I can't interpret these findings, but I did have kind of a question based on something you had said earlier as well. But I think one of the concerns I've heard about BIP and what you mentioned was that because it's focused on this percentage rebalancing measure, another way to get a higher percentage of HCBS is to specifically reduce access to institutional care and make it harder for people to access that if they're on Medicaid. So
yeah,
it almost seems like this result could come from two angles. One is like they're not specifically restricting access to institutional care, or another is like even though they're increasing HCBS, it's not kind of having the downstream effect of institutionalization. But I was wondering if you had another way of getting at that, like access question that you had heard from some of the stakeholders.
Yeah, and there's this kind of pejorative term, but I'll use it, this word work effect of getting more people into the system as a result of BIP. So just more people coming in because they were being able to assess eligibility much more quickly and connecting them to services. So maybe both HCBS and long-term institutionalization stays went up because of BIP. And so there's not a reduced effect, but there's just kind of no effect. So I think we need samples with greater power. And unfortunately, we're still waiting for more years, our analyses of more years of data. So I think it would be nice to be able to look at some. By the way, this was so complicated. And I should mention that Jordan Harrison at RAND was leading this paper with Sarah Edgington as our analyst. It was extremely complicated just to describe the pathways of the MCBS beneficiaries and coming in and out of the MDS and implying, where they might be if they're not observed as having a long-term institutionalization and institutionalized stay. And so that was just a tremendous effort to put that together. And I think with the MCBS being nationally representative, but limited in sample size, we could be coming against power, statistical power.
Dana, I was curious in this analysis if you stratified by other factors aside from race and ethnicity, because I wonder if there's a bookending problem sometimes where those who are at the lowest risk of nursing home entry are still receiving BIP, but they offset an observed effect. And on the other side, if those are at the highest risk, BIP isn't going to do much. And so I'm curious if you could stratify by some indicators of risk.
Yeah, I was just trying to pull up Jordan's paper. I don't remember exactly. I think we may have looked at rural urban as well. And I also think that the benefit of looking at MCBS is that unlike with claims data, MCBS is a survey. And so you do have information about family caregivers. And so one thing that we would love to look at is people who live alone, just their living situation. We can't always imply that they're family caregivers, but just somebody who's living alone might just be very high risk or short survival time to an institutionalized, a long-term institutionalized stay. Yeah, thanks for the questions. If I go to the chat, am I going to disrupt the view of the?
I don't see anything yet.
Okay, just wanted to see if there's anything else that I could answer in the chat. Oh, I see.
I'll let you know if more things come up, Regina.
Okay.
So you don't have to get distracted.
Oh, thank you. Yeah, and thanks, Mary, for coming on and asking your question. Thanks. So, I'm going to shift to something that's not necessarily BIP specific, and that is about rebalancing and the workforce. So one thing we wanted to know is, how has the long-term care workforce shifted given rebalancing efforts? And so these maps show geographic variation by state. And we're looking at workforce changes per 1,000 persons with disabilities. And we're looking at years 2009 to 2020. And so a darker red color means that a state experienced a decline in workers per capita, and darker green indicates faster growth. And so we're looking at home care workers per capita and nursing home workers per capita. And so what we're finding is that over the last decades, most states have been increasing their home care workforce. And that states are increasing their home care workforce, but also decreasing their nursing home workforce. But interestingly, that substitution is not one-to-one. So in these bar graphs, we see that the average growth is 145% for home care workers and a resulting decline in nursing home assistants. So that capacity for home care workforce is increasing at a faster rate than the nursing home workforce capacity is declining. I'm going to move to another workforce paper that we published, and I am just super excited about this, and I want to know if anybody else is excited or not. It is a very, very exploratory study. Because of this direct care workforce challenge, we have the availability of family caregivers that's declining because of greater female workforce participation, smaller family sizes, and later childbearing. And at the same time, the affordability and accessibility of formal caregiving requires either very low income, roughly stated, or very high income to afford out-of-pocket care. Because the direct care workers have insufficient pay, few benefits, and little recognitions, turnover in this industry has been perpetually high, especially during the pandemic. So when I say direct care workers, I define that as personal care aides, home health aides, and nursing assistants. So I would love to take any guesses, either come off mute or in the chat, your guesses on the median hourly wage for personal care aides, home health aides, and nursing assistants. No Googling.
We need to have a Zoom poll for this.
Yeah.
Yeah, really. We have a wide range coming in the chat from 7 to 15, up to 18, 11, 16, 11, 14. Okay, full range between 7 and 18, it looks like.
Yeah. This is a very knowledgeable audience. So it's 12.27 is the median rate per hour. I think that was in 2018 or 2020. Any guesses on the turnover rate of home care workers? 0 to 100%.
So how do you define that per year? What is that?
That's right. Number of percentage of workers leaving the workforce per year. So in 2018, there was an 82% turnover rate for home care workers. And at the same time in the United States, the rest of the country was experiencing a 15% turnover rate. So these workers are leaving the workforce entirely, changing to other industries that have higher pay, including the restaurant industry. And so we know that some of these workers are leaving home care agencies either because of family reasons or, the benefits are not sufficient, even though they really want to be staying in this workforce and they love what they do, and they're just not receiving sufficient recognition. So one thing that I had heard when I had done this long-term care policy blueprint with my colleague Esther Friedman. Esther was the one who led the health affairs paper on the workforce changes by state. She and I had heard that some direct care workers were leaving the regulated agency that they loved, but wanted greater take-home pay. And so they were working under the table to get more, a higher take-home pay. And so this is, I would love your feedback on this. So I was curious, and I coined it the gray market. What is the rate of gray market use? And so I roughly defined it, because there had been no definition previously, as a workforce of paid providers who are unrelated to the care recipient, not working through a regulated agency, potentially unscreened and untrained, and potentially paid under the table. And since there was no data on this topic, I searched far and wide. I wanted to conduct a study to understand what is the prevalence of gray market use in the US. And so I took a tiny bit of pilot data and just wondered, can I even find these people? And so with the tiny bit of pilot funding I received, I could only afford 3 questions through the RAND American Life Panel. So the RAND American Life Panel is a nationally representative standing web-based panel maintained by RAND. Respondents are given a computer and internet access if they don't already have it, and the sample is weighted to be nationally representative of adults 18 and older. RAND American Life Panel is used extensively by federal agencies like the CDC during COVID pandemic. Fields surveys very quickly with really beautiful data. There are lots of offshoots like the American Educator Panel that provided a lot of data on how teachers and principals pivoted during the early days of the COVID pandemic. So I highly recommend the RAND American Life Panel. So within a couple of weeks, I got this wonderfully weighted data from ALP. And the way I approached it was, I could only get a sample of that 6,000. And I really wanted to find this gray market community. So I thought there's kind of 3 groups here. One is the care recipient down at the bottom. Terrible icon, I know, but you get the idea pretty quickly. You have the care recipient in yellow, and you have gray market providers in gray. I was concerned that the ALP is not likely to have very many of either if they need care or if they're in this gray market. They're either impaired or have disabilities, or they're busy caregivers trying to make an income. They're not likely to be part of a standing web panel. So I came at this from the caregiver angle, somebody who is arranging gray market care. So that is who I targeted, the care arranger in the ALP. So in 2017, we fielded a survey of about 1,000 adults randomly sampled from the American Life Panel. And I asked adults in the survey, I asked if they had ever had to arrange paid care for someone, so the care arranger, or for themselves as a care recipient. And if they did arrange paid care, whether they sought care from someone they hired outside of a regulated agency. And so I had a series of 3 questions with skip patterns, and it had things like, where'd you find this person? Care.com, church, neighbor, friend, other relative. And I also had a full sample, and I had a dementia sample of people who were doing, trying to find gray market care for somebody with dementia, either themselves or the care arranger. So we did descriptive and bivariate analyses and adjusted logistic regressions with sampling weights. And what I wanted to do was estimate the odds of being a gray market consumer, somebody who's hiring paid care through this gray market. And then also doing the same for someone living with dementia. So what we found was that nearly 1/3 of adults who arranged paid care sought care from the gray market. And they were finding these gray market workers through church friends. They were neighbors. Not a lot came from care.com or websites, but they were also talking about people who were currently or formerly working for regulated agencies, and they wanted more stable hours and had increased loyalty to one family. So if you're a direct care worker, sometimes you have to cobble together hours of care because you're not allowed to work more than a certain number of hours straight through. So oftentimes you're going to 3 different families, or on Monday, Wednesday, Friday, you go to one family, Tuesday, Thursday, you go to another family. And a lot of families don't like that either because they have preferences of care that maybe one direct care worker really understands better than another. And so sometimes the family will say, why don't you just come work for me full time and I will pay you, and you just leave your agency. And sometimes it can be a great arrangement, sometimes not. And so that's what we were hearing about, these gray market workers. In the adjusted,
Regina, oh, sorry to interrupt you. Did you specifically exclude those providing child care?
yes. So in the preface, we talked about caring for somebody with needs who is older than, I think, 50. I can't remember exactly the question, but yeah, we did have a preface kind of preceding the survey questions describing what we meant.
And Medicaid care would all be in the other category.
That's right. Yeah, so not through a Medicaid agency. But I think,
Although,
Catherine,
like, what about self-directed Medicaid care or something like that?
yeah. Although I think self-directed, you can choose who to pay. You would still be kind of officially a directing Medicaid to provide that reimbursement. But I think, Catherine, that kind of like analogy of parenting care and nanny care kind of came, that same kind of question about like, are you considered an employer? If it's a certain number of hours, you have to file income taxes and withdraw income taxes, et cetera, if you're a domestic employer. So we also kind of thought about like, there's an analogy here for childcare.
We do have a couple of questions in the chat. So maybe we can try to take those now before you move on, Regina. Is that okay? April, do you want to ask your question, or should I go ahead and read it?
I can try. Can you hear me? I'm so sorry. I'm in sort of a loud place. I was just wondering if there was like any evidence out yet. I know this is really a lot of difference between quality outcomes between the two, because I know anecdotally or just based on laws, we have a lot of trouble with paid agency caregivers, because a lot of them aren't required to have any dementia training. Many of them do not provide medications unless you're paying extra for people with extra advanced training. And so like, then I have patients who have great relationships with their more gray market providers, and you can have a little bit more liberal interaction with them in the clinic setting because it isn't through some sort of red tape area. So I'm just wondering if you're seeing like a difference in quality, because to me, when I see this information, I'm like, who cares, right? And so I just want to know if you're seeing outcomes.
Yeah, I think that the presumption is that this is lower quality care because nobody's really qualified to supervise it in the home. But I actually think that the care could be of superior quality than from a regulated provider who's an agency who's overseeing the worker. I think it's completely open. And it's an open question. I don't think anybody knows. And I think your question about dementia care is especially pertinent when I'm trying to write a proposal around this idea, and I've started engaging gray market providers, and they have said to me that they are incredibly proud of the work that they do, and they want to be trained better to do it well. And they talk about dementia extensively. They were like, this person had very mild symptoms. It's now progressing. I don't have any training whatsoever. And even if they were working for a regulated market, a regulated provider, they don't always provide dementia capable training either. So they're now in the gray market side, and they're saying, I have no means of getting trained to provide dementia capable care to my consumer. And I really need that training. And so why aren't, like, this is happening, why aren't we providing better training and interventions for them? Because they're already there. And so they're struggling, and they really, they don't know what to do. They've never had this experience before. And so, they may have been offered that in a regulated agency. I'm not entirely sure if that same kind of training carries over in the gray market realm. If you could just take that same kind of training and give it to a gray market provider. I don't think so, because there's just so much more that a gray market provider knows if they're providing round the clock care to somebody with dementia, and only for that one person. So I love your questions, April, because I don't know the answers, but I can tell you that the gray market providers are seeking it. They really want it. I will also say that some of the gray market providers are wanting to know what their pathway to citizenship is, and sometimes worry about not getting paid. And other times there's only positive glowing things that they have to say about working for their one family.
There's a few comments in the chat, and I just want to highlight, Cynthia raised a really important issue around whether people might seek the gray market if the care recipient doesn't speak English, and they might want to find a culturally similar care provider, essentially.
Yes, and that is part of the reason why we think this gray market is occurring, is because we have more diverse older adults in the United States, and they want language concordant care, and they're not getting it from the regulated market, especially if they live in rural areas. And so I'll just quickly move to the next slide to answer that question, because people living in rural areas among the dementia sample were 5 times more likely to go to the gray market. And that is suggestive that they're just not finding language concordant care or enough hours of care that they want from the regulated market because they live in a place that's just doesn't have accessible services to them.
Hi, Regina, can I just comment? And I've been doing some work in Maryland, interviewing care managers that help facilitate these services, the implementation of home and community-based services through the agencies. But one thing that I just thought of when you were mentioning this piece is that one of these supports planners is in a rural-ish area of Maryland, and commented that a lot of times she sees a lot more family caregivers that are being paid, like paid family caregivers, because the agencies are just not present. So it's not even, I mean, I don't know the capacity of the agencies that are able to provide care, but they just don't exist. And, you know, to meet the demands of the that are in those less populated or, you know, more rural areas. And so a lot of times family caregivers. So I imagine that's sort of the same story that you would see here in terms of the gray market use.
Yeah, absolutely. And I think family caregivers who are financially compensated for their care also need better training to provide care. In this case, I have defined gray market as people who are unrelated, but there are some similarities with the family caregiving, which, you know, we can't describe as unpaid. These categories are overlapping now. These are not mutually exclusive. So that's another issue I think that you pointed to, is it's not just formal, informal. It's not family versus formal. It's not paid versus unpaid anymore.
So we have just 5 minutes left.
Yeah.
And I know there's a lot of excitement and enthusiasm. So I don't know if you want to conclude the presentation and that we have some time for some questions.
Sure. Yes. So I kind of forgot about these findings for a while, but then I thought, you know, I really should publish them because I haven't seen anything else. So I had submitted this paper and got some nice uptake. Also, Esther Friedman's work and Dan Ziganolfi's work has also been featured in some of these media stories. So, you know, this is very exploratory, the gray market findings, but I'm hoping to do some work on that. So I'm going to go through these last slides pretty quickly. I just have a couple more. So California Medi-Cal is the largest Medicaid program. And so they are going through some reforms, which means that there are some new initiatives, CalAIM, to improve the quality of life and health outcomes across the Medi-Cal program. And so I've just listed a couple of challenges here with measuring HCBS quality. And so because of those managed care plans that are going to be increasing under the CalAIM reforms, and how there's going to be a lot more new forms of Medi-Cal HCBS, they're also responsible for ensuring high quality care. California Health Care Foundation asked us to lay out in a report considerations for measuring, reporting, and monitoring the quality of Medi-Cal's HCBS. So in that report, I won't go through everything, but in that report, we talk about examples of structure, process, outcome measures, and we also talk about some examples of quality measurement initiatives in other states. In particular, I love, you know, Colorado's Providers of Distinction Network, which designates providers who deliver higher quality care and have better care outcomes for HCBS members. And then New York Uniform Assessment Tool is also using data to inform eligibility, assisting providers in care planning, and then they publish performance data on LTSS plans. So it helps consumers decide where they might go. And then some new initiatives, nothing yet formal, about value-based payment for HCBS. So I'll conclude with just one quick slide about the Candy Network. So following all these projects, our work has progressed to focusing on dementia HCBS. I think measurement of HCBS is particularly challenging for people with dementia. And so we have this new research network called Community Care for Network, or CANDY. And so we are fostering knowledge. Our goal is just to connect people with each other, grow and diversify the bench, facilitate translation of research into policy through trainings, carry out all of our activities through a DEI lens. And we're recruiting members. So it's obviously free to join, and we hope you will sign up at the URL code, or the URL or the QR code. Our goal is really to accelerate research on the measurement of HCBS, access, quality, costs. And so we're hoping to do a lot more in this area by supporting you, the community of researchers, the community providers, and also policymakers. So that's the whole purpose of Candy. So I'll close by just thanking you all for inviting me to speak today and for your great questions. And I also wanted to acknowledge our funding and our wonderful team at RAND, UCLA, University of Michigan. And so thank you so much.
Wonderful. Thank you, Regina. So we did put the link to Candy in the chat, so everyone should check it out and sign up for it if they haven't already. And I don't know if we have one burning question for Regina. That's about all we have time for. Okay, well, if we don't have a burning question, I will just point out there's a ton of enthusiasm around the gray market that we're seeing and sort of what that choices are in the chat. We can definitely save that for you, Regina, so that you can kind of think about that as you advance this work, because it's clearly an area that's of a lot of interest to people.
Thank you so much.
Thank you so much for your wonderful talk today and joining us.
Thank you.